Hi, my name is Saloni Thakrar, and on behalf of Healthwatch Camden, I would love to welcome you all to this event. It's wonderful to have so many participants join us this evening. We have about 100 people registered and joining us this evening. Because we're such a large number, I would like to go through some housekeeping rules, which will allow for a better running of the meeting. Everyone joining this event will be put on mute, and if you try to unmute yourself, you'll be automatically muted again. Apologies in advance for this. We also ask everyone, except for our panelists and our BSL, British Sign Language interpreters, to keep their videos on. Everyone else, if I could please request that you turn off your video. This is so that it helps improve your online connection and means that you can see us properly and our interpreters easily. Also, there is no chat function tonight for this meeting. It has been disabled. This is because there's so many of us, and to minimize any distraction and disruption, we just wouldn't be able to keep up with the comments. And we want to keep up with the meeting, of course, and the event. The meeting is being recorded, so you can watch it again if you miss anything. And we'll also be providing a full transcript of the meeting, which will be available on the Healthwatch website. We'll also be emailing you the links and the resources to everyone who've signed up for this event. I would like to take this opportunity to introduce our two British Sign Language interpreters, Liz and Russell. Liz, would you mind waving and saying hello? Liz, are you there?
Can you see me?
Great.
I am here.
Great, thank you. And Russell?
Hi, everyone.
Great. If you are a BSL user, you may wish to pin the interpreter so they can stay large on your screen. To do this, please hover over the images so that they remain visible. Elizabeth and Russell will swap over during the session from time to time. For everyone else, the event will be best experienced in speaker view mode. So if you go and click on the right-hand corner of the screen and put it on speaker mode, that'll be really helpful. If you're following us on social media this evening, please tag us at HealthWatchCam, and please tweet about the event and tag HealthWatchCam. Thank you. This is a question and answer session only, and I will be asking the questions on behalf of our participants and all the members that have joined us this evening. Thank you to everyone who've submitted their questions. We received about 50 questions, and of course we can't get through all of them. So I'm going to ask about 18 to 20 questions based on the ones that you've submitted, and I hope we'll manage to cover many of the issues that you've raised. We'll also be sharing the full list of the questions with the panelists so they can follow up later on if we've missed anything. And here to answer our questions, I'm delighted to introduce our panel. Dr. Neil Gupta, GP, Camden elected governing body member, NHS North Central London Clinical Commissioning Group. Also joining us is Dr. Kaz Sayer, retired GP and chair of Haverstock Healthcare GP Federation. We also have Dr. Daniel Beck, GP and chair Camden Health Evolution GP Federation. We have Dr. Farah Jamil, GP, co-chair Camden Local Medical Committee and executive team of the GP Committee England. And we also have Amal Wicks, who's a practice manager from Brondesbury Medical Centre and chair of Camden General Practice Managers Forum. And the panelists today broadly will represent the views of GPs and practices across Camden. While your GP practice might not be referred to this evening, the views will remain mostly the same across most GP practices. So to get us started, I'll ask our first question of our panelists will be, okay, Neil and Farah, I think we're all quite concerned about our lockdown tomorrow. As we enter another period of lockdown with rising COVID infection rates, what changes will patients see in GP practices? Farah, can you shed some light on this and give us some assurance around this?
Sure. Thank you very much, Saloni, and thank you for giving us the opportunity to talk to patients quite candidly and openly. Thank you very much. So I think I want to say minimal, given the huge change that has already taken place in lockdown version 1. So all the business change that was required overnight happened at a practice point of view. And I recognize the frustration, the anxieties, and how that has felt for patients. And so I use the word minimal. But what sits behind that is remote working. So overnight practices responded to the lockdown announcements based on guidelines that came down from NHS England. And we moved to working in a way that protected patients, protected practices and their staff. So at this moment in time, what we will start to see is perhaps more of that. We're still awaiting formal further guidance from NHS England if things should change in lockdown version 2. But having said that, looking at some of the appointments data that has just come through nationally, what we do know is that over this last month, more than 50% of appointments were actually delivered face-to-face. So I don't want colleagues and patients to feel that GPs are closed. They're not. They're open, they're seeing patients in the usual way, based on need, based on priority. So if you need to see your GP, they will organise to see you. And hence why I use the word minimal at the start. But there are other things that are slightly different. So PPE, for instance, you might be rung up before your appointment and talk through about your symptoms. You might be asked to fill out forms. You might be taken through what might happen in terms of when you come in for your appointment. You might have to wait outside your practice and be called in specifically at a certain time. And that's really to minimize risk of infection, both to yourselves, to your family members, but also to the practice staff, so they can carry on providing services and keep seeing you as a patient as you need to be seen. I might just take a moment just to mention a few other aspects though. So at this moment in time, we're currently faced with the largest flu campaign that we have ever seen in the country. And a lot of that is falling to general practice to deliver. So there are competing priorities, one with the delivery of the flu vaccination. And you might have picked up today from the news about COVID vaccinations potentially on the horizon, and the role that general practice, as you can expect, will then play in safeguarding our patients. There's also other conversations being had around the clinically extremely vulnerable patients and the services that might need to be provided to them. And I mention all of this because it all comes down to prioritizing where our time is being spent and how we provide care to those who most need it. So hopefully minimal change in lockdown version 2, but these are some of the competing challenges that we are currently working with. And I haven't even talked about the backlog, the secondary care backlog piece, the diagnostics that are currently being challenged, the systems being so challenged, blood tests just can't be done. There's a huge waiting queue. So I appreciate, again, the anxiety and the frustrations, but do know that general practice is open. We are seeing patients all day long, every day.
Thank you for that. Thank you, Dr. Jamil, for that, for the reassurances and the level of deep detail. Neil, did you want to add anything to this or comment on what Farah said?
Yeah, thank you, Saloni. And firstly, very nice to see so many familiar faces, very fleetingly, but really nice to see a lot of people. I'm going to try and build on what Farah said rather than duplicate. I mean, I think I would echo what she said. A lot of this depends on how high the levels of COVID get, but if if things stay broadly stable, then the change we'll see in general practice will be minimal because the big changes have already happened. And practice worked at an incredible pace during the first lockdown and the first wave of the pandemic to put in place new processes such as increased use of digital tools, triage processes, to make sure that we could provide a resilient and a safe service. And I think it's that key, safety is the absolute key, keeping our patients and our staff safe. So all of our practices now have established and embedded safe ways of working. In terms of the levels of COVID, Camden, we have seen a rise, as with every other area of the country since summer. Camden it has consistently been the second or third lowest level of COVID. What we've seen in our hospitals is we've still seen only a fraction of the numbers of people admitted with COVID compared to the peak in March and April. So if this lockdown, this national lockdown, has the desired effect, hopefully that will help to keep things stable, or in fact even reduce the levels of COVID, and we can carry on delivering comprehensive primary care. So that's both proactive and reactive care safely to all of our patients. And I think, I want to just echo that point. There is a difference between this lockdown and the first lockdown. I think sometimes the language is unhelpful. If you think about the first time around, there are quite significant changes here. Not everything is shutting down. So the most obvious example is schools. So schools and educational settings are open. But similarly, from a healthcare perspective, during the first wave, large parts of the NHS did shut down. And speaking personally from a general practice perspective, because of the volume and the complexity and the novelty of what we were dealing with, we were largely left being able to deliver reactive care for people who were seriously unwell. We're not in that position at the moment. I really want to emphasise that general practice is open, and no one should shy away from coming forward to their GP if they are worried. And no one should not attend routine appointments such as a smear during this lockdown. The NHS is open and offering a comprehensive service during this second lockdown. I want hopefully that message comes across. The one thing I would ask, though, general practice is open, but I would ask, and I think Farah's alluded to this, is understanding. So general practice is open, but everyone is working incredibly hard behind the scenes to make sure that we can offer that comprehensive, safe service. And everyone has been working incredibly hard since the start of this pandemic without a break. So if things don't always go as smoothly as they could, or if non-urgent things take a bit longer than they would ordinarily, then please, a bit of understanding with your practice will go a long way.
Thank you, Neil. Thank you for clarifying and the in-depth answer on this. Moving on, the next question is, I know many people have expressed satisfaction with telephone consultations. Most would like to speak to their named doctor each time, but are not often offered this opportunity. Are any practices thinking of ways to address this issue? Dr. Kaz Sayer, Kaz, would you mind sharing your thoughts on this?
Thank you very much, Saloni, and it's a great pleasure to see so many people. And I just wanted to start actually by thanking, on behalf of the practices, they specifically asked me to thank the patients of Camden for their understanding and support during a really challenging time. So I just wanted to start with that feedback from the practices. So I know from Healthwatch's own report that actually there are quite surprisingly really very high satisfaction with telephone consultations and the new digital systems that have enabled patients to be able to contact and be in touch with their practices while keeping both patients and staff safe. I would say that every single practice recognises that the importance of continuity of care, and particularly for those with long-term conditions, mental health and physical sort of complex cases. And we recognise the feedback from the Healthwatch that has been an issue for some of those groups of patients. But it has been, as Neil's already alluded to, quite a challenge to introduce new ways of working at such a fast pace, and also given that quite a lot of staff themselves have been off sick or shielding, and that continues to be the case. I think it's fair to say that for some practices it's probably easier to address this issue and ensure that people have that continuity of care and speak to the same person, probably easier in some practices than others. But some of the ways in which we're looking at it are, some practices are already offering routine telephone appointments for named people. And that will, I think, as these new systems embed, will become easier to do. And particularly, hopefully, as we move towards the end of the winter challenges we're facing at the moment. And I suppose the other way in which it's starting to be addressed is because quite a lot of the increasing demand and the resilience in practice is being met through the additional staff that are coming to join general practice. So people like clinical pharmacists, social prescribers. And that is designed really to be able to free up doctor time and to enable then the doctors to be able to spend the time with those people for whom it is particular necessary, and there's a particular need to have that kind of continuity of care. So I don't think it's perfect, and I do reiterate what Neil says, a bit of understanding, just to understand how quickly and how complex it's been to introduce new systems. But I think it is starting to improve, and certainly the practice is looking at ways to address this.
Thanks, Kaz. That was really helpful and really clear, honest reply there. Amal, would you mind taking this question? When are GP services going to see patients again face-to-face as the primary mode of operation? Would you be able to share your thoughts on this?
Yeah, well, just before lockdown, we were seeing patients face-to-face. As the main mode of operation was, first of all, telephone triage, assessing needs, and then calling the patients in. The GPs at our practice are very keen to see patients face-to-face. They just feel that a lot more can be done face-to-face. As we just started in July, August, and opened the front doors and started the process again, this is now version 2.0 has kicked off, or will kick off from tomorrow. So I think the ambition is there to see, to do face-to-face as the main mode of operation. But we also have to do some assessments of risk on our staff and of our premises, because if we get sick, then if the staff get sick, especially the clinicians, then we would need to be more mindful. So I think it is, the desire is there, but I think we need to take a practical approach first and assess risks before we say, yes, we want to do it face-to-face all the time. I think it's taking a sensible, practical approach.
Thanks, Mark. Thanks for sharing that. Dr. Farah Jamil, our next question is over for you. One of the participants asked, I am really dissatisfied with GP appointments. I must wait 4 to 5 hours for a call back, sometimes even longer. I feel totally forgotten, neglected, and abandoned. I am shielding and isolating. Would it be possible to have an experienced nurse or trainee doctor on hand to answer telephone questions that patients might have? What's your position on this, and what are your thoughts?
So I'm going to try and divide this question up into 3 different areas. And I think really to begin with, I just want to acknowledge the frustration, and I'm sorry that this has been your experience. I share that frustration. 2 years running, I have still not been able to register with a dentist. That's a slightly different problem. but I acknowledge your frustration. And I just want to then try and move into the shielding aspect specifically, and I'll come back to address the beginning of the question again as well. So shielding in its original form has changed, and I think it's important for that nuance to be because it is different. Government has moved away from the concept of shielding this time around. They're describing it as clinically vulnerable patients and then providing guidance saying, if you cannot work from home, then if you fall into this list of clinically vulnerable patients, we are writing out to you so you will know who you are, and you can use that letter as proof to your employer or for things like statutory sick pay, etc. So shielding as a concept is slightly moved on. They're not necessarily advising everyone to stay indoors, stay at home, but definitely minimize contact where possible is what's being recommended at this moment in time. And again, some of this is very much being driven by government and the Chief Medical Officer's office. So we're all still learning about some of these concepts. So I would say for the most up-to-date information, if you are a patient who identifies with the concept of shielding and clinically extremely vulnerable, you will be written to nationally, and it will tell you what you must and mustn't do. That's the bit on shielding. In terms of services then, so taking 4 to 5 hours to receive a call back, based on that, what I understand from it is that the patient is trying to access further advice from their GP surgery for a condition or for a specific issue. And the GP is having to go through their list of patients and prioritize and accordingly get back to the patient in due course of their day. And I guess what is not necessarily always visible to everybody is all the other competing priorities coming into the GP's workbook. So 111, for instance, directly books into a GP's appointment slots, and they can be a whole variety of different things that get booked in, and I might have to drop something and focus on that. Another team member might be dealing with something complex in the surgery, and I might have to drop what I'm doing and deal with that specific issue. And this is just describing the normality of what might occur within a practice. So the 4 to 5 hours can seem a very long time, but it is because of what the list of priorities that the GP is having to deal with. The other thing perhaps to also mention is there are other wider members of the team, and I think the question does reference trainees and nurses who are constantly, and they are part of our team providing care to patients. They are constantly fielding queries coming in, requests for further clinical advice, etc. But there's also other ways of being able to see a GP. So some surgeries have switched on direct bookable appointments. Some surgeries are making available e-consult to access advice through that means. And if there's an absolute emergency and you cannot wait, the GP is just taking far too long to respond to your needs, we would always recommend that if things are changing, that 111 is relied upon or A&Es are relied upon if there's a changing situation. So there is always clinical advice on hand, and I'm sorry that we can't always get there immediately, but we are working through and getting there at some point through the day.
Thanks, Farah. I'm going to move us on. That was a really comprehensive answer, and thank you for that. Neil, would you like to take the next question from one of the members? Is it possible for the medical record system used by University College London Hospital, My UCLH, to be merged with existing systems from other hospitals and GPs so that appointment details and letters for each patient are easily accessible to both patients and medical practitioners?
Okay, thanks, Saloni. Similarly, I'll take that in two parts because I think there are two different facets to that question. One is about access to that sort of information, letters, results, etc., for healthcare professionals, and the other is for access to that information for patients themselves. So firstly, in terms of healthcare professionals, I think this is a good opportunity for me to highlight an important change that's happening in Camden. Some people will be aware of, but perhaps not all. So many of you in this meeting will be aware that we've had for a long time the Camden Integrated Digital Record, or CIDR, which brought together information from the major healthcare providers in Camden alongside information held by adult social care. It's with quite a heavy heart earlier this year we made the decision to decommission CIDR and I'll say a little bit about why that was. But speaking as someone who's been quite heavily involved in that programme for a number of years, probably the most difficult place from which to access and extract data is the hospitals. And that's because they all use multiple different IT systems. And even within a hospital, there are multiple different record systems, multiple different IT systems. And so there is a huge amount of effort and ultimately cost that comes with trying to do that, and it's not always feasible. You compare that to general practice, where nationally there are 2, maximum 3 different IT systems in use in general practice across the whole country. And so I think our experience with CIDR was that when we tried to work with our hospital colleagues at UCLH or the Royal Free, quite legitimately they would challenge us and say, well, if you want us to do this, and Islington wants us to do something slightly different, and Barnet wants us to do something slightly different still, that's a huge cost and a huge amount of work, and we're not really sure with everything else that we have to do that we can do that. And actually, probably the weakest part of CIDR ultimately was the hospital information. So we know, in particular from UCLH. So as we speak in Camden, having said that we've decommissioned CIDR, that is being replaced by something that is a tool covering all 5 boroughs in North Central London, which is called the Health Information Exchange. And in contrast to CIDR, I would say the strength of that system is the ease with which it can extract that sort of information, letters, appointment details, results from our hospital systems. So, so I think that's a huge benefit for us. So practices are starting to switch this on. It is available to all practices in Camden. They're starting to switch it on as we speak. And for those who are interested, you could pick that up with your practice just to understand when they're planning to go live with that. So, for example, you could be seen at University College Hospital, and clinicians there would have access to your GP record and your letters and notes from the Royal Free, which I think is a big step in the right direction. So I wanted to flag that. In terms of patient-held records, the situation, I'll be frank, is much less promising. And this is something we've talked about for a number of years, about bringing together all the different patient portals into one patient-held record that would cover information from all different healthcare providers. If I'm being honest, in the last 5 to 10 years that I've been part of this, I haven't seen a huge amount of progress in that. And I think, being realistic, in the foreseeable future, I think people are going to be left with individual means to access their information from their GP, individual means to access it from UCLH, etc. And in my experience of speaking to patients, I think people are comfortable with that so long as those things work well. Personally heard very good things about the UCLH portal.
Thanks, Neil. To all our panelists, we've already reached halfway and we've still got another 12 questions to ask. Can I request that you limit your answers to 2 minutes or slightly less, because we've got quite a few more questions to get through. And I know this, these are really important conversations, but I'm going to have to request that you limit your answers to 2 minutes. Neil, again, over to you. The next question is, we have received a lot of feedback about eConsult, both good and bad. Please, can you explain what is eConsult and how effective is it? What steps have practices and the clinical commissioning group taken to find out about patients' experiences of making appointments online, telephone triage, and visiting surgeries?
Okay, thanks. Yeah, so I'm already on the naughty step after my lengthy answer to the last one, so I'll try and be as succinct as possible. So I think that a lot of people will already be familiar with eConsult, but it's essentially it is a tool to communicate with your practice without having to pick up the phone, wait for a long time. We've already heard about that experience, without having to make a face-to-face appointment. In very simple terms, it is an electronic form which will allow you to convey information to your practice. It will do that by asking you a series of structured questions and allow you to enter some free text. Now, essentially, it's allowing you to outline your needs. Some of those needs could be fairly simple and administrative, in which case that will be dealt with by the administrators in the practice. Some of it could be complex clinical information, and that will be reviewed and I'm going to speak just personally about our practice. That will be reviewed by a clinician, a doctor or a nurse, and you will get a response by the next working day. I think in terms of where we are now, it's been an absolutely essential tool in our armoury in terms of putting in place those safe arrangements for offering that comprehensive service through the pandemic. It's something we talked about for a long time, but it's really accelerated through COVID. In terms of the evaluation, this is new to, but not new to the NHS. This is used throughout the UK. So there hasn't been a specific Camden evaluation, but evaluation has happened across the country in different sites. And generally, patient satisfaction is high, from memory in the 70 to 80% bracket. And I think that what that says is that this works really nicely for most, but not for all. So I think there is a real, there is a real benefit for a lot of people, but it's really important that practices have alternative methods of communication for those for which this isn't suitable. So, for example, people with communication difficulties, frail elderly patients, and I think that's part of setting this up, is making sure that everyone still has access to the practice and that we don't create a two-tier system.
Thank you, Neil. And thanks for highlighting those that, may be limited by this. Dr. Daniel Beck, thanks for waiting so patiently. The next question is for you. I would like to ask if more home video calls and phone calls can be introduced and made permanent. I found recent contact better when visiting a practice. Will there be more weekend and evening opportunities for phone calls and video calls? We'd love to hear your thoughts on this question.
Thanks, Saloni. It's absolutely wonderful to hear a really positive example of how the system has changed and actually benefited some people during this pandemic. And I think the first thing I'd say is that many practices already offered telephone appointments, whether that be in terms of assessment or routine appointments. And so there was a significant amount of experience among the clinicians and amongst the practices there. I think my sense very strongly from practices is that the future will hold a mixed model. It'll be resuming a business as usual face-to-face element, but it would be wrong to dispense with something which has proven so valuable for so many in terms of the convenience, in terms of the accessibility, in terms of the really quite, an example, especially during the COVID pandemic, when we were assessing children with fevers, adults with breathing problems, to be able to very quickly switch to a video consultation, assess someone's breathing state, look at a child's rash, say, okay, well, let's do this again tomorrow. Let's speak again by video tomorrow and see how your daughter or your son has their condition has changed. It really presents enormous opportunities there, and I think we all really valued that. It feels in some ways like 10 years of tech progress has happened in 10 months, and at the beginning within 10 days. And while some people love video, I've had feedback patients who suffer with things like social anxiety. They really value the ability to speak and share their thoughts without the stress of being in front of another person. Many others greatly miss the connection, the subtleties of seeing their GP, their clinician in person. So I think evening and weekend appointments, absolutely, they've moved almost exclusively to telephone and video and can largely remain that way. And I really think it's worth flagging that there have been advantages for our diverse workforce also. It's amazing what can now be done without being in the practice. We were talking about highly secure internet connections for viewing medical records remotely, for being able to issue prescriptions remotely. It has tremendous benefits for our workforce also. So I think it's really nice to be able to focus on some of the positive benefits and the positive effects of the pandemic in terms of digital inclusion.
Thanks for sharing so much light on this, and also highlighting that we hope to hold on to some of the areas that have really worked, and particularly for our patients around access. The next question is, I'm concerned about digital exclusion of people with no access to digital equipment. Do practices know which of their patients cannot effectively use a digital device? What provision will be made for patients who do not have a computer or telephone, or the patient has a disability or sensory impairment? How are practices managing this?
There's a lot to unpack there. I think that's a really fantastic question. There's a lot to that. I think, and I just want to start by saying that it's worth really acknowledging that one of the tragedies of the pandemic is how that it's really exacerbated the inequalities that are already present within our communities and made the lives of those living in challenging circumstances even more challenging. And we're really having to think creatively about how to circumvent that. So, I mean, I think if we try and take the question piece by piece, and I'll try and do it as briefly as possible, mindful of the time. I think that we do have patients with no internet. We've got very few patients with no telephone. And yes, I think we do know who they are because we've been engaging with them outside of the normal appointment booking process for some time. It's worth saying that email, even amongst the very frail, amongst the very elderly, is an even more vital tool for some of those people housebound, living with severe disability. And I think that there's incredible solutions that's creative ways that our patients use text to speech, speech to text on phone devices. Accessibility on smartphones is quite remarkable. In terms of meeting people's needs where these remote solutions aren't possible, the default is always seeing people face to face, people attending the practice, and practices are aware that specific arrangements have to be made, and as Neil said at the start, practices are able to see people safely in the vast number of cases. We're also working really closely with our community providers, our mental health trust, our community nursing teams and their integrated primary care teams to really support the frail and vulnerable who struggle either on the telephone or on video or to come into a practice, perhaps who are living alone, perhaps older people with mental health problems. And there's been a real value working with Age UK and Voluntary Action Camden around their volunteer networks that they rapidly mobilised, really identifying those who are very isolated either physically or digitally. One example just to briefly mention was the COVID testing buddies service that we rapidly mobilised with Voluntary Action Camden from the federations to support those that were requiring a COVID test but couldn't navigate the online test request or the 119 telephone number, and linking them with a volunteer who would support them through the arranging of the test and doing the test and posting it back. And then I think my final point on this is around our shielding patient lists, that it really provided a wonderful opportunity to do some proactive reaching out to those people who we knew to be vulnerable, to be frail, to be isolated, and to really take a proactive look at addressing some of their needs and tapping them into some of the support services that rapidly sprung up at the beginning of the pandemic.
Thanks, Dan. Thanks. That was really, really helpful, and it's just really reassuring to see that you're working so hard and also reaching and working so collaboratively with groups from the voluntary community sector and working on solutions to support some of these groups. The next set of questions are on flu vaccines. Kaz, what are your thoughts on this? Is there sufficient vaccine available for everyone to receive their flu vaccination? Is there a consistent approach to rolling out the vaccination to vulnerable people or groups? I'd love to hear your thoughts on this.
Thanks, Saloni. So the answer to the first part of that question is a qualified yes. So just to give a little bit of context to that, so practices and pharmacists order their vaccine at the beginning of the year. And they do it based on last year's numbers. And of course, this year there's a significantly widened group of people and a drive to try and vaccinate as many people as possible. So it's just within that context. What we have done is to use what we call a flu calculator, which estimates by practice how many people need the flu vaccine, how many vaccines were ordered earlier in the year, and then what the gap is, so that we can ensure that further stocks are ordered. And I think the first thing to say is that in general, it's been more of an issue of encouraging people to have it. And I would like to take the opportunity to really, really encourage everybody who is eligible for a flu vaccine to have it, because it's important this year. In terms of have we got enough supply, there have been some delays in the supplies, particularly for the under 65s, but that's actually resolving. And we now have access to additional supplies. So I really don't think that's so much of an issue. In terms of, is there a consistent approach? Yes, there is a consistent approach. It's about doing the high risk first. So that's the elderly, those with long-term conditions, children and pregnant women. The focus has been on delivery through the usual routes first, as far as possible. So that's practices and community pharmacists, particularly for two reasons. The first is because obviously they have the experience of running these clinics. The second, I think, is really because we want to reconnect people with their practices in particular, and take the opportunity to do checks and to assure people that their practices are open for business. But we also are collecting at the same time feedback from the practices and data around those groups who are not accessing the normal routes for their flu vaccination, and trying to understand firstly who they are, and then secondly why they're not accessing it. Largely that is either a communications issue, so we're working with public health and local authority and community leaders to try and encourage people to have the flu vaccination. But the second thing is that many of them are fearful about actually coming to healthcare facilities. So we're also looking at additional places where that flu vaccine could be delivered in settings which are both culturally and accessible to people, places like community centres or where food banks are. So that's really how we're trying to address the consistent approach.
I'm going to move us on to the next question, because we've only got about 10-15 minutes left. Kaz, this one's for you again. Could you explain advanced care planning and the importance of advanced care planning in the context of COVID? And how does general practice support advanced care planning in care homes? Very briefly, thank you.
Okay, I'll try to answer it very briefly. So the concept of advanced care planning is really to allow a discussion between professionals and patients and their families and carers about their preferences and wishes regarding their care and treatment, and to then agree plans to ensure that those preferences are delivered, and that those care plans can then be shared across different settings. And that helps then to make decisions in a crisis. When it could be that somebody is transported, for example, to A&E, they themselves may be very poorly, it may be difficult to get hold of their relatives, but if you've got a care plan, it then sets out for people what the preferences of the patient and the family are. Obviously, that's very important in COVID, partly because people become unwell quite quickly, and there's obviously a much higher risk of hospitalisation if you are elderly and have COVID, but also because there are barriers to being able to have your family in that setting to help make those decisions during COVID, in terms of the fact that, you know, it's very difficult to visit people, for example. In terms of the care homes being supported, so the care homes all have named GPs, and a fundamental part of the work that those named GPs do is to work with other professionals and the staff at the care home with patients, their families and carers, to actually draw up those care plans and make sure that they're kept up to date and available. And it forms the basis of any discussion as well. So supposing somebody is actually taken into another healthcare setting, and the GP might get contacted to get a little bit more context around a patient that they know well, again, they can use the care plan to share the preferences of the patients and their families and carers.
Thanks, Kaz. That was really, really helpful and very clear. Dan, the next question is for you in relation to mental health and homelessness. One of the questions that was asked is, what is general practice doing to help the health needs of the homeless population in Camden. Can you explain the role of CHIP? If you could tell us what the acronym is, and how does a homeless person register with a GP? Thanks.
Thanks, Saloni. So I think there's a couple of different parts to that. So I'll start with what GPs are doing to support our homeless population. I think the first thing to say is that through a really well-established GP education programme, there's been an annual training for all GPs in Camden around homelessness, where we've brought in various experts as well as people with lived experience of homelessness. And it's because of Camden's position as a central London borough, it's a topic that I think GPs locally have a relatively good amount of experience with, and I think it's something that we can be quite proud of how we address it. So every practice in Camden maintains a homelessness register, and that includes street homelessness as well as people living in hostels or sofa surfing or in other precarious or vulnerable housing situations. As part something that Camden commissions locally is we have an enhanced service where all practices are signed up to a process by which we proactively invite all of our people on homelessness register for an annual health check. And that's a physical health check, it's a mental health check, it's an opportunity to make sure that people are taking up their screening opportunities, be that cervical screening, sexual health, HIV, hepatitis, and also really to see how the person's doing holistically. Do we need to tap them into mental health services? Have they fallen out of referral pathways, addiction services, drug and alcohol services? I think that I think that it's something that all practices do, and it's something that I think that largely we do relatively well, although it's a constantly evolving problem. I think that it's worth acknowledging that, especially during COVID, we've really seen every day the precariousness of some people's lives with regard to their housing, the stress, the physical health consequences of poor quality or unstable housing, and how quickly people can fall through the cracks. I think that probably brings me on to CHIP, which is Camden Health Improvement Project, which is a bespoke homelessness practice based just in central London, just on Hampstead Way. It's a service that's been commissioned for the last few years, and they register patients who are predominantly street homeless, especially patients with substance misuse, sexual mental health problems, or those who find it difficult to engage with mainstream services. And they provide a really holistic approach, supporting the range of their patients' needs. They're co-located in the Marguerite Centre, which is where Camden Islington Mental Health Trust have some of their services, especially around opiate substitution and alcohol services. And they have an outreach function as well. I've been able to confirm with CHIP that they've remained open for face-to-face assessments throughout the COVID pandemic. They appreciate that their cohort of registered patients often have chaotic lives. They've never operated an appointment booking process. Their registered list know that they can turn up and that they will be seen, and they've continued to operate in that way, albeit with PPE and social distancing and all the precautions that they're able to take. Just mindful of time, registering, there was something about registering, how do homeless people register. Part of the education, part of the training for GP practices is there isn't an obligation for all practices to register any homeless person that comes and seeks to register at their practice, as long as they are within their area. For particularly chaotic or difficult to manage homelessness, the CHIP obviously has the specialist expertise, but nearly every practice in Camden will have a cohort of homeless patients registered on their books, and they can use a variety. So some will use the practice address as their registered address, and that's something we all have experience of.
Thanks.
Have I covered all the points? I think I probably have.
You most definitely have, and then it's very impressive to understand, you know, the amount of work that's going in this area. So thank you for that. Moving on, Kaz, are practices working more closely together? Oh, sorry, I think I've missed one. Is there a risk that video or telephone consultations will miss certain serious symptoms, such as cancer, that would be identified during a face-to-face consultation? How are GPs supporting people who are on waiting lists for hospital care? Can you share, your views on this? Thanks.
Sure. So, I mean, the first bit of that, the risk of that we will miss certain serious symptoms, I think that is a fear that is shared universally amongst professionals, GPs as well. And I think it's something that, particularly at the onset of the introduction of these newer technologies, people were extremely worried about. I actually think that the evidence probably doesn't bear that out as it being any more of a risk than the risk that exists anyway. But and the reason for saying that is that there is the telephone consultations are often quite detailed. There is the ability after the phone or a video to offer further tests, and patients have been able to access those throughout. And of course, the other potential is to bring somebody in for a face-to-face examination to examine them. And as Farah pointed out, that's about sort of 50% of the work that's currently happening. The evidence is that while 2-week waits, which are the way of actually referring people urgently because you think they may have cancer, did drop in the first few weeks of the first wave, but they have steadily picked up to near normal rates now. So that suggests that people are continuing to be referred where there's a concern that they've got something serious the matter. In terms of how they're being supported, and I think everybody feels very sorry for those people who are stuck on waiting lists for hospital care, even if you understand the reasons for it. GPs have taken on enormous workload from secondary care in terms of organising investigative tests, checking up with people. If there's a deterioration, finding urgent ways to get them actually seen in the hospital via emails or via 2-week waits. And I think they're also doing a lot more in terms of advice and guidance, so phoning up the hospital consultants and having advice on how to manage people during this very difficult time. But I don't think anyone can take away from the fact that it is a very difficult time for those on hospital waiting lists. And I think everybody feels very sad about it.
Thanks, Kaz. That's very helpful and some very useful information there. Farah, our next question is, how are practices managing the routine care of patients with long-term conditions?
So I'm just going to turn this a little bit on its head because I think nothing feels like routine at this moment in time. But it was used earlier, proactive care. And I think that's something that practices have been doing where possible, right from the start of the pandemic, proactively reviewing their patients, reviewing the most vulnerable, reviewing the shielded group. The shielded group, by the way, is a dynamic registry, so it's constantly changing. So on a daily, weekly basis, practices are going through those lists and looking at whether they need to put other things in place, contact the patient and organize further care for them. Now that might perhaps pick up a subsection of patients with long-term conditions, but that does pick up a certain chunk. Outside of that, for patients who are on long-term medications, there will be a process of clinical review that practices do every time they sign off a script. When was the last time the patient had a blood test? When was the last time their parameters were reviewed? Does this patient now qualify, for instance, for a diabetic check? Do I need to review their asthma indicators? Do they need to come in for a check? And this is constantly happening behind the scenes at a practice. So where relevant, the patient will be contacted and either they will organize a remote review where possible, and if necessary, bring the patient in for a face-to-face review. But it's proactive would be perhaps the word at the moment I would use. And then perhaps the other thing is the flu campaign at the moment is, again, that other opportunity to check in with the patient, because a large number of patients with long-term conditions actually fall into the at-risk group for flu vaccinations. So that's another checkpoint to review the patient when they're coming in for their jab and just assessing them for their long-term condition.
Thanks, Farah. That was very helpful. Neil, I'm going to move on to you. The next question is, what is the general practice doing to help patients from the Black, Asian and minority ethnic communities? And how is the Camden Clinical Commissioning Group working with the council and public health in supporting the residents from these local communities? Can you shed some light on this? We can't hear you.
Sorry, let me unmute. Yeah, thanks, Saloni. So you'll appreciate this is a very complex issue. We don't have a huge amount of time, so I'll try and cover some of the key points. I think one of the things when we first started to see that there was a disproportionate impact on our BAME communities from COVID, as healthcare professionals, I think our minds sort of gravitate towards biological, physiological explanations. Was there a genetic explanation, receptors, enzymes, all of those sorts of things? But actually the reality is far more simple and far more depressing. A lot of this is down to the same reasons that we've known about health inequalities for years, and they're not medical and they're not biological. A lot of this is societal. So a lot of our people from our BAME communities work in sectors where they can't work from home. They're on the front line. They may not feel empowered to get the protections that they need at work. And there are lots of small contributing factors to this. I think from a healthcare perspective, one of the things that we identified very early on was about the importance of the public health messaging cutting through to all of our communities. And actually, if we go for a one-size-fits-all approach, as the NHS does, NHS England does, it's very likely that those key messages will not reach all of our communities, and they certainly won't be understood by all of our communities. So I think the focus, and I have to give huge credit to Camden Council, one of our key partners, they have taken this issue very seriously from the onset of the pandemic, not just considering the health implications for certain communities, but also the economic implications of COVID and the disproportionate impact on them. And working collectively with the council and public health, in terms of short-term approaches, really the focus is on getting those key public health messages out there, working with local VCS groups to try and do things differently and not go for that one-size-fits-all, to try and make sure that the messaging that we have is supportive, it's culturally competent. And it's not just about COVID. So obviously there are messages around COVID. Initially it was stay at home, protect the NHS, all of that sort of stuff. There is a risk of a double whammy of non-COVID harms as well. So probably the thing that we talked about a bit on in this meeting is flu vaccination. So actually a really important thing is maximising flu vaccination amongst these groups. And actually, can we use more targeted, more nuanced messaging to reach into our communities and make sure that we maximise flu uptake amongst these groups? And from a commissioning perspective, we've specifically incentivised GPs to target BAME groups for flu vaccination, because we know that traditionally rates can be a little bit lower in there, and it's a really important, potentially life-saving intervention. There's lots more I could talk about, but I'm very conscious of the limited time we have. But I think it is about that more nuanced form of communication.
Thanks, Neil, and thanks for touching on the main points there. I just want to apologise ahead of time that, we are going to be running slightly over. I think this is a really important conversation. We are going into our last question, but apologies if we run over. Farah, this one's for you. Many people are becoming increasingly inactive with closure of services and fear of using gyms. How are healthcare professionals supporting residents to become physically active during the pandemic? And what services or activities are you referring towards?
So this one's a slightly challenging one, isn't it? Because I'm with you there. I'm one of those people who was scared to go to the gym. I used to go to the gym 5 times a week, and I was absolutely not going to step inside a gym, not with the current, with the rising levels of COVID. In any case, we're now going into a lockdown, and gyms will be closed. I did, though, through lockdown, manage to lose 10 kgs. So There are a few things that we can do. We can all encourage each other and we can all support each other. In terms of actual services, I think, again, services are very much reliant on groups motivating each other. And at this moment in time, it's very hard to train as groups. It's very hard to meet as groups, but there are a lot of virtual forums. So things like Slimming World, etc. They've set up virtual forums. But I'm just going to talk a little bit about exercise, because I think it's a moment to sort of plant a seed and encourage people to consider going out for a walk, or perhaps just walking indoors in your house. So one of the things I did was I went on YouTube and I looked up walking videos and I broke them up into small chunks, 5, 10 minutes, 15 minutes, and did them throughout the day, no less to give me a break from some of my meetings or some of my working day. But I did them through the day and that helped. Joe Wicks, let's not forget, the nation's PE teacher, you know, he has announced that he's going to be doing 3 sessions a week through lockdown. They're not going to be at an ungodly hour anymore. They're going to be on YouTube, so you can engage with it as and when you want to. So that's another option, possibly. I know there's a lot of personal trainers all over Instagram and YouTube who are uploading video workouts, which you can go and engage with. They're free content. So the key message really is keep moving, keep active, don't lose faith. And soon as it's possible and safe for us to restart groups and services, they will be back up. But in the meanwhile, there's so much more that can be done. You can still go out for a walk with up to 1 other person from outside of your household within the rules, as long as you're not within a clinically extremely vulnerable group.
Thanks, Farah. Thanks for sharing those very practical tips and ways of staying active, especially as we move into the second lockdown. It's really, really important that we maintain, you know, fitness levels and take care of ourselves. We've received 50 questions from our participants. Thank you to everyone that's come this evening and for submitting your questions. We've tried our very best to answer your questions. Many of you won't have heard the specific question, but I hope our panel has captured something that you want to know. Please continue to email us with your queries. We will try and get them answered. Neil, do you have any thoughts about, you know, if our participants have any concerns or want further clarification, where should they look for these answers?
Thanks a lot. I think probably the simplest thing, if people are contacting you with questions, they're very happy for the CCG to be the conduit for those questions. And we may not be able to answer them directly, but we'll make sure we connect people with the right person and get those questions answered. And Martin Emery, who many of you on this call will know well, will be a good person to be that conduit, I think.
Thank you. So please share your questions with us, or if you have any anything that you'd like to ask, we will forward that to Martin at the clinical commissioning group, and we will have those answered. Thank you again to our panel, Dr. Kaz Sayar, Dr. Dan Beck, Amal Wicks, Dr. Farah Jamil, and of course Neil Gupta, Dr. Neil Gupta, for taking the time to join us this evening, and to all your staff in primary care and at the Commission in your practices for your incredible devotion, your hard work and care throughout this time. And of course, going forward, we want to wish you the very best. I want to also thank the Health Watch team, Martin and Colette, working behind the scenes for making this happen, and to all our participants for joining us this evening. It's always awkward and frustrating not being able to see each other, and apologies that this wasn't an interactive session where you weren't able to ask your question. That's just the nature of this meeting, and I apologize again for that. But before I end, I would really like to invite all of you to switch on your cameras so that we can Thank you. On that note, I'm going to say goodbye. Thank you.
Right.